Hello, can you hear me? 107 are here. Any more to join? No. Will I wait for a while? We got to discuss about chronic kidney disease in children. Um, this is an up and coming important topic in current medical field because as you are aware about the chronic kidney disease in adults, there's increasing tendency in the country of increase chronic kidney disease in adults. But in the counterpart of pediatrics, we are not seeing that amount of high increase, mainly because probably the causative factors of chronic kidney disease among adults is multifactorial and the long-term implication rather than short-term. So probably we don't see the impact in childhood. Maybe during adulthood only they tend to manifest the problems of this high-risk exposure, like heavy metals and arsenic and things like that, which are implicated in adult. But there's a significant number of children who are suffering from chronic kidney disease. Issue is at the moment there's no proper long-term structured program for managing chronic kidney disease in children, because compared to adult renal failure, in children, issue is complex because now long-term treatment, say a man of 45 years get a kidney transplant, say he's going to live up to that 70 years. It's about 25 years more of management with anti-digestion drugs and other follow-up management. Say a 7-year-old child going to get a renal transplant, it's a very long way forward, and treatment cost and then the side effects of drugs, side effects of immunosuppression. So the long-term implications are more. So management of chronic kidney disease in children has become not has been established as in adult, because it's a very big ask at the moment. Like having a transplant program for children has not been properly been even addressed at the moment. So at the moment, what we are doing is actually managing them with the supportive treatment until the complications set in, or decreased kidney function leads to other complications which lead to death actually. So at the moment there's a structured program, and we are mainly managing them, keeping them comfortably as long as they live and manage them appropriately. But I think it's area that need to be addressed. Now we are into liver transplant in children. So by not kidney transplant is an issue. But main difference between kidney transplant and liver transplant is the liver has the capacity to grow, whereas kidney doesn't have the capacity to grow. So you even transplant a small part of liver, it will regrow and produce more liver tissue, hepatic tissue, whereas the kidney will not, that will not happen. And so with there is a more likely to have complications with post-renal transplant. Right? So anyhow, at the moment, situation is that it's sad, but there's no structured approach at the moment. So we'll see what we can do for these children until such time. Right? Hope for things are moving very fast, very forward in positive manner. So hopefully something will happen in near future, right? So that's sort of an introduction for you until the other people join in. As far as exams are concerned, it's an area of upcoming interest, right? it's very unlikely for you to be given a long case with chronic renal disease, right? But theory, MCQ, SCQs, there's always a possibility of getting cases and questions on this area, right? Especially in MCQ areas rather than SCQs, but even can be touched. That areas may be touched even in, if you get a child with renal urine tract infection, recurrent urine tract infections, and which is poorly controlled and having some structural renal damage. So discussion may move on to chronic renal disease. Right? Though the child is not having chronic renal disease, discussion can be drifted to chronic renal disease, and then you may be questioned on that areas. Right? So you don't have to actually have a case on chronic renal disease to be discussing it. So you may not have a chronic renal kidney disease patient in a long case, but discussion can drift into that area. So safe it is to know about the basic facts, at least about the chronic kidney disease, right? So this lecture is a comprehensive one. So for anyone who wants to know the finer details, I have included, right? But I'll be highlighting the main facts that we should know. Anybody who wants more descriptive and more finer details, you can go through the entire thing. The presentation has all the minor details as well, or I can read further depending on the facts given in the lecture, right? So then we'll move on. You got 130 participants. Will be more than this, or can you move on? We'll move on. The time is 10 minutes past. We can 10 minutes to join, right? So what is the definition of chronic kidney disease? It's defined as a structural or functional kidney disease lasting for more than 3 months with or without reduced GFR, right? That means there is evidence of either structural kidney damage or functional kidney damage. That means with the imaging or biopsy or any other matter, or by abnormal biochemical parameters in blood investigations. If it suggests that there is a chronic kidney disease lasting for more than 3 months, right, you can diagnose chronic kidney disease even without having a low GFR, right? Because sometimes the initial part of chronic kidney disease, there can be even increased GFR. We'll come to that later as we go on discussing, right? So GFR is not necessarily to be low for you to diagnose chronic kidney disease. That's the important thing you have to highlight here in this statement, right? You can have chronic kidney disease with normal or even increased GFR, but evidence of either structural or functional kidney damage, right? That's the one definition. Or it can be GFR less than 60 ml per minute per square meter, 1.73 square meter. In this PowerPoint thing, I made this PowerPoint. I couldn't get this hyperlink, super link one. So I just put it there. It should be square meter, right? So we generally express the GFR in according to square meter, and standard policy is the standard adult square meter is 1.73 square meters. So we just express it. Then we calculate GFR. We ultimately correct it to 1.73 square meters, right? So if it is less than 60 ml per minute per 1.73 square meter, that indicates chronic kidney disease. So there can be decreased GFR without evidence of structural or functional kidney damage. So it's either way, right? So you can have evidence of structural or functional kidney damage with or without GFR reduction, or you can have reduction of GFR with or without structural and functional kidney damage. So what you have to remember is that either reduce GFR or structural or functional damage evidence for more than 3 months is enough to diagnose chronic kidney disease. So both these are not needed to come to the diagnosis, right? So I hope you got the point, right? So because the pathogenesis of chronic kidney disease, there is actually loss of glomerular function, right? Some of the glomeruli are lost due to some pathological process. So we will discuss the pathological process which leads to loss of glomeruli. But anyhow, for time being, we remember that some injury to the kidney, right, will cause some glomeruli to be destroyed. And then what happens? The remaining glomeruli will try to compensate for the lost glomeruli by hyperfiltration. So they will try to maintain the GFR by working more. Like if you have 5 people in a ward, 5 doctors in the ward, if 2 are ill, other 3 will have to work more to cover up the work of the missing 2 people, right? So they will be more tired. Something like that happens here. Say there are 1,000 glomeruli and 500 are destroyed. So remaining 500 will have to filter more to produce same GFR, right? So that is what I call hyperfiltration. And hyperfiltration itself is damaging to the kidneys. This will lead to sclerosing of the functional glomeruli as well. So they work harder and they tend to get destroyed as well. So there is progressive destruction of glomeruli, right? So the initial insult is something toxic to the lung, kidneys, but that initial insult does not need to be there for the progression, right? Progression, once the initial damage has taken place, progression can take place without the initial damage continuing, because hyperfiltration itself will damage, right? So the most important reason for chronic kidney disease is hyperfiltration, right? So this is the most important contributing factor for chronic kidney disease, because this leads to progressive kidney damage. In addition, most of these conditions in the kidney will lead to high proteinuria as well. The loss of protein in urine, and protein get deposited in renal tubules and cause further damage, right? So proteinuria is a feature of chronic kidney disease, and itself it's damaging to the kidneys as well. And then most of the condition in kidneys will lead to activation of renin-angiotensin system, which will cause hypertension. And hypertension in turn again damage the surviving nephrons. So it goes on damaging. In hyperphosphatemia, that is due to increased phosphate level. Here the phosphate excretion is less. Increased phosphate level cause again damage. So these are 4 main reasons why the progressive loss of nephrons take place, right? So once the active process has taken place, these will continue the continuous kidney damage, right? So there are, out of these, the most important one is hyperfiltration. By the way, there is a mass going in the church, and they're using loudspeakers. Probably they're not sure that God can hear them, so they want to have loudspeakers on, right? Is it disturbing to you all, or can you hear clearly? Sorry? Okay, that's fine. So you are not disturbed. I just think I have to go to another room that have it more soundproof. It's okay, no? Okay, right, fine. Right. So we move on. So what is hyperfiltration injury? As I told you, right? What happens? Either the afferent arteriole become dilated, so more blood come to the glomeruli, or efferent arteriole get constricted, so the resistance to blood flow increases, and then more blood pressure inside the glomerulus will increase, or the glomerular basement membrane changes cause increased permeability of the glomeruli. So by either of the mechanisms, you can increase the filtration, right? So filtration depending on the hydrostatic pressure inside the glomerular tuft, right? So if the afferent artery get dilated, more blood will come into the glomeruli, and the glomerular pressure will increase. So more fluid will be filtered. If the efferent arteriole is constricted, then there is more resistance to blood flow. Again, the interglomerular pressure will increase and more fluid will be filtered. If there's increased permeability of glomerular capillaries, then again more fluid will be filtered. So one of these mechanisms, the glomerular filtration can increase, right? As I told earlier, that itself will be damaging further. So this is the most important component of how the kidney disease progresses, right? Is it clear? Okay, right? So this is what I emphasize there. So what are the conditions that lead the initial insult? Initial insult that damage the kidney. What are things? Viscouric reflux with recurrent urinary tract infection leading to renal scarring. In children, this is one of the common causes of chronic kidney disease, right? Because in some children, now urine normal when the bladder contracts, urine goes into the urethra, right? It doesn't go back to the ureters because there's a valvular mechanism between at the junction of ureter and the bladder. So there is a the ureters enter at an angular direction. So when the bladder constricts, the ureteric opening automatically get constricted. So urine won't go back to the ureters, right? But in some conditions, there are this valvular mechanism is incompetent. So when the bladder contracts, some of the urine go back to the ureters, right? And then when the bladder relaxes, the urine come back to the bladder. So there's always urine in the bladder, and bladder urine being a good growth medium for bacteria, there's increased risk of urinary tract infection. So that's how UTI is more common in mu reflux, right? And that cause recurrent that infected urine to go up as well because there's reflux. When the urine bladder contracts, the infected urine go back up to the kidneys and cause infection in the kidneys. In addition, due to this increased reflux, the pressure is transmitted to the kidneys as well. So due to various mechanisms, the viscouric reflux can cause kidney damage. One thing is infection. Second thing is the back pressure on the kidneys, right? So by either way, VU reflux can cause chronic kidney damage. Another thing is when there is a neurogenic bladder, when there's an like spinal problems or any cerebral palsy, when there's a neurogenic bladder, normally when the bladder contracts, the sphincters relax and allow urine to go out from the bladder. When there is neurogenic problems, you get what they call detrusor sphincter dyssynergia. That means when the bladder contracts, the sphincters won't relax. So what happens? Urine can't go to the urethra, it will go back to the ureters and cause a reflux, right? So in either way, that causes damage to the kidney. That's why the neurogenic bladder can result in chronic kidney disease because it is a sphincter dyssynergia, right? And then any obstruction to the urine flow. This is common in boys who have posterior urethral valves. In some boys, in the prostatic part of the urethra, there's a mucosal fold which acts as a valve. It won't allow urine to come out of the bladder. So there's increased resistance to flow, and then that increases the bladder pressure, intravesical pressure, which is transmitted to the kidneys, and due to that, the kidneys get damaged. So these children with posterior urethral valves get changes in the kidney, what you call it, dysplastic kidneys, right? So in response to obstructive uropathy, any obstruction downwards, the kidney undergo changes, which is called dysplastic changes, and that can lead to chronic renal failure. So in the children with posterior urethral valve, significant posterior urethral valve, even if you correct the posterior urethral valve very early, there will be progressive renal damage, which will need to go into end-stage renal disease ultimately, right? So any child who has a posterior urethral valve, even if they operated, they should be followed up, and there should be a plan for managing chronic kidney disease because they are at risk of chronic disease, right? And then any history of acute nephrotic syndrome, Henoch-Schönlein-Purpura, these, like now generally the commonest nephritis in children is post-streptococcal glomerulonephritis, which does not usually go into chronic kidney disease. It's a transient thing. It completely recovers. But there are some nephritis which are not completely recovering. Yeah, they can go on progressing, ultimately leading to renal disease, right? Usually something like HSP. Any perinatal renal problems, right? Family history of kidney disease or risk factor. The displays it all about high place is all about it. Right? So any systemic disease, diabetes, hypertension, which you can have in children as well, they definitely cause kidney damage. And then autoimmune condition like SLE vasculitis. So if you have these things, there's increased risk of damage in the kidneys, right? So if you have these factors, there's increased risk of having chronic kidney disease in later life, right? So how do you diagnose chronic kidney disease? You do the estimation of glomerular filtration rate, right? So it can be calculated by constant, K is a constant, into height in centimeters divided by serum creatinine. So you need serum creatinine and height in centimeters, right? This K is 0.413. Then you multiply it with the height in centimeters and divide by serum creatinine. Then you get the estimated glomerular filtration rate. So depending on the estimated glomerular filtration rate, you decide whether the child has got chronic kidney disease or not, right? So how do you stage it? Stage 1, there is more than 90 glomerular filtration rate with evidence of kidney damage, structural or functional kidney damage, but GFR is normal, right? Normal GFR is 120, but up around 90, above 90 is taken as normal, right? So you can have high GFR or normal GFR with evidence of kidney damage, then it's stage 1, right? And then when there is evidence of kidney damage with GFR mild reduction, that is 60 to 89, then stage 2. When GFR is 30 to 59 is called stage 3. Then stage 4 is 15 to 29. Anything less than 15, then it's called renal failure, right? Renal failure which needs dialysis for survival. So up to this point, right, you can go on without dialysis. When it comes to stage 5, when the GFR is less than 15, then you need renal replacement therapy in the way of dialysis or transplant, right? So up to this stage, you call chronic kidney disease, right? When the GFR is less than 90, you call it chronic kidney disease, right? But then I can contribute this more than 90, but with evidence of damage. That's I told you earlier, right? In the definition, you can have normal GFR with evidence of kidney damage, right? That is for stage 1. So these all stage 1, 2, 3, 4 are chronic kidney disease, right? And stage 5 is end stage renal disease. Now, don't get mixed up with the definition, terminology, right? So up to stage, all these stages are chronic kidney disease, right? But stage 5 is the end stage renal disease. That means without renal replacement therapy, child can't survive. Okay? Is it clear? Any questions up to now? Are you clear about it?
Yes, sir.
Anything clear to clarify up to now? Okay. We'll go on then. If you have anything unclear or unclarified, just start then and there, right? Then you can stop and discuss about it, right? Right. So what you do in your investigation, you can do ultrasound scan of the renal system to look for size of kidneys, then scarring, shape of kidneys, abnormal dilatation of pelvic system, right? All those structural abnormalities can be diagnosed by a ultrasound scan, right? So if you think of reflux, then you have to do for with hysterogram, right? Things are there, but those are imaging studies. You can do various imaging studies. Basic is the ultrasound scan. Then if you think of renal abnormality, you can go for biopsy and diagnose what's going wrong in the glomeruli, what the pathology in glomeruli. Then you can do various blood investigations to find out how bad the disease has progressed. So basically, a lot of investigation you can do, and all can be categorized under these three headings, right? So what are the complications they can develop due to chronic renal disease? A child with chronic kidney disease will have several complications, and one of them is the growth retardation, right? So one of the main difference between a child and adult is adult has stopped to grow, whereas child is still growing, right? And with chronic renal disease, there is growth retardation, and this growth retardation is multifactorial, right? There is mainly growth hormone resistance, right? Not really growth hormone secretion inhibited. Growth hormone is secreted, but growth hormone can't act because of the changes in the receptor level, at the receptor level, right? So there's resistance that causes decreased growth velocity, and then malnutrition, because these children have poor appetite and there are dietary restrictions, so they're malnourished, so that will affect their growth. They're anemic, right? We discussed that why is anemic. So anemia causes chronic tissue hypoxia. Any chronic tissue hypoxia will cause growth failure, and they will have metabolic acidosis, and metabolic acidosis, any acidosis for that purpose, will suppress the growth plate, the growth cartilage. So the bone growth will be inhibited if there is acidosis, right? And then there's metabolic bone disorder, where there is bone problems in because vitamin D and phosphate metabolism is interfered, so bones won't grow properly. So for normal growth, the bone should increase in size, right? So that will also affect it. And then commonly these children will have delayed puberty, and most of them will not go into puberty because of chronic disorder. They will not go into puberty, so then they won't get the pubertal growth spurt because sex hormones are not coming in, so they will not get the pubertal growth spurt, so they will be shorter than normal, right? So that's the reasons for growth failure in chronic renal failure. And then most of the children will be anemic, right? And again, anemia is multifactorial. Main reason is erythropoietin deficiency. You can remember physiology. One of the main functions of kidneys is production of erythropoietin, which act on bone marrow to produce red cells, right? So hello? So that's one of the main reasons for anemia in chronic kidney disease is erythropoietin deficiency, and then there are iron and folic acid deficiency, right? Because of dietary restrictions, poor diet, and then they are having high blood urea levels and other nitrogen compounds. Those will suppress the bone marrow. Uremia will suppress the bone marrow and production of red cells. And then these children have hyperparathyroidism, which can lead to myelofibrosis. That means the bone marrow gets fibrous, so there is no enough bone marrow to produce red cells, right? So anemia is again multifactorial, but these two are the most important, and these also contribute towards the anemia, right? And then they have bone problems, right? Two main reasons for bone problems. One thing is, you can remember your physiology again. Vitamin D is cholecalciferol, and it is 25 hydroxylated in the kidney, liver, and 1 alpha hydroxylated in the kidneys. Right? 1 alpha hydroxylase action is taken place in the kidneys. So this is the active form of vitamin D. So even if you have vitamin D taken enough amounts, if it's not converted to this form, it will not be effective, right? So in the children with chronic renal failure, they can't produce the active form of vitamin D. So the vitamin D action will be reduced, and that will affect the calcium metabolism, and they will be having bone demineralization with the osteopenia, right? The bone will be less dense, right, and easily fractured, and bone growth will be retarded. On the other hand, because of the phosphate, which is the decreased number of glomeruli, phosphate which are filtered will be reabsorbed, so that the serum phosphate levels will increase. And if you can remember your organic chemistry, calcium phosphate is not a easily readily dissolvable compound. It dissolves only small amount. ප්‍රත්‍යාර්ථ ප්‍රතික්‍රියාවක් තියෙන්නේ ඉදිරි ප්‍රතික්‍රියාව හිමින් වෙන්නේ පසු ප්‍රතික්‍රියාව වැඩියෙන් තියෙන්නේ. So that calcium phosphate get ionized only in small amounts to calcium and phosphate. In any condition when there is phosphate level going up, the calcium level will go down, right? Because the multiplication of calcium and phosphate is a constant. The calcium ions and phosphate ions multiplication is a constant. So if phosphate level goes up, automatically calcium level will go down. That will result in low calcium level, low serum calcium levels in blood. That will stimulate the parathyroid gland to stimulate PTH. That will cause resorption of the bone. Right? So you will get demineralization of bone because of the increased parathormone secretion. Right? And again, there will be metabolic acidosis, and that will contribute again to the problem with the growth plate and normal functioning of the bone marrow, right? Sorry, bone. So there can be again bone problems because of multifactorial problems, and these all are important in this vitamin D active form, not form, increased phosphate, and these two are coming together, right? Ultimately, there will be secondary hyperparathyroidism. After secondary parathyroidism, for longer duration, it becomes autonomous, becomes tertiary hyperparathyroidism. Right? Secondary hyperparathyroidism means you get low calcium levels. In response, parathyroid gland secretes PTH. And if you leave that situation for longer duration, right, the parathyroid can become autonomous. It will start secreting parathyroid hormone even when the calcium levels are normal, not only when it is low. That's what we call tertiary hyperparathyroidism. Secondary is only when the calcium levels are low, right? If you don't treat at that level, correct it at that level, go to tertiary hyperparathyroidism, where even with normal calcium levels, PTH levels will increase and cause bone resorption, right? So that is the reason for the bone problems in chronic kidney disease. And this is what give a summary of what happens in post calcium metabolism, right? And then they will have metabolic acidosis. That is because kidney is one of the organs that are involved in acid-base balance. There are two main organs involved in acid-base balance. One is the lung, other one is the kidney. So kidney control the carbon dioxide level and control the pH by increasing and decreasing carbon dioxide concentration. Whereas kidneys control the bicarbonate level, and increasing and decreasing bicarbonate level, kidneys can alter the pH level. Right? So kidneys can reabsorb bicarbonate filtered in the glomerulus. In addition, kidneys can generate bicarbonate by combining from breaking down from carbonic anhydrase, right? So kidneys can produce bicarbonate or reabsorb bicarbonate. So in kidney disease, what happens? The bicarbonate metabolism, the bicarbonate reabsorption, bicarb production will be interfered. So serum bicarbonate levels will drop. So when serum bicarbonate level drops, you can remember the Henderson-Hasselbalch equation, pH will drop. So there will be metabolic acidosis, right? So metabolic acidosis means when the bicarb level drops and cause acidosis. Respiratory acidosis means when carbon dioxide level increase and cause acidosis, right? So you can have two acidosis types, metabolic acidosis and respiratory acidosis. Respiratory acidosis when there's a lung problem causing increased carbon dioxide and causing acidosis. Metabolic acidosis mainly in kidney problems, there is decreased bicarbonate and causing acidosis, right? Similarly, they can have hyperkalemia because amount of blood filtered at the kidneys are less, right? So less potassium is filtered into the glomerular filtrate, and out of that, majority will be reabsorbed, right? So the blood potassium level goes up. One of the main complications of chronic renal failure disease is potassium retention. So we get hyperkalemia, and then because of the high ammonia levels and blood urea levels, and actually what we measure is blood urea, but there are other nitrogen compounds produced during metabolism of tissues which are excreted in urine, small amounts, right? And these nitrogen compounds, low molecular weight nitrogen compounds, also accumulate in chronic kidney disease, and they can cause neurological problems, multiple neurological problems, and worst form is encephalopathy, right? So these are other complications they can have due to chronic kidney disease. So in addition, they can have hypertension, we told early, because that is due to the activation of renin angiotensin mechanism, hyperlipidemia because of this, some of the glycoproteins are lost in urine, and that leads to hyperlipidemia. And then because of any effect on bone marrow, and due to effects of drugs that are taken, they are immunocompromised. And in chronic disorder, they are immunocompromised, so they get recurrent infections. And they have increased bleeding tendency, that is mainly due to platelet malfunction. In uremic condition, platelet function is reduced. So their platelet number may be normal, but even they can bleed because the platelets won't stick together normally. They can get glucose intolerance, and due to uremia, they can get pericarditis, pericardial effusions, and due to acidosis, they can get left ventricular dysfunction. So these are other complications they can have when the renal GFR gradually goes down as the child progresses towards end-stage renal disease, right? So this is the flow chart. So initially child is normal, and then child is exposed to risk factors, and then risk factors cause kidney damage, that causes the GFR to drop, and then that causes hyperfiltration injury, and then ultimately kidney start to fail in its function, can't continue with normal functions, and then child go into chronic kidney disease and end-stage renal disease, and ultimately death, right? So all these can lead to complications. Complications in turn contribute towards the chronic kidney disease and ultimate death, right? So this is a progressive thing, right? It's progressive thing gradually towards the end-stage renal disease and death, right? So each of these make complications. Complication make the renal damage more. That's what you say, right? So it's a vicious cycle-like thing, chain-like thing, right? As the disease, as the kidney damage progresses, complications set in. Complications cause more renal damage, right? So it's a vicious cycle. So if you want to stop the progression, you have to manage the complications appropriately so that it won't cause further kidney damage. So how can you reduce the progression? How can you slow down the progression of chronic disease? We said earlier that hypertension and proteinuria causes kidney damage, and we said the most important factor of progression is hyperfiltration. They have been trying to find ways of reducing hyperfiltration, and they were unable to find a way of, still not been able to find a definite way of reducing the hyperfiltration and thereby reducing the progression. So it's not an option available, right? So reducing hyperfiltration is not an option, but we can control the hypertension and proteinuria, both of which can damage the surviving glomeruli, right? So the idea is to keep the blood pressure below the 50th percentile, both systolic and diastolic. Generally, we could talk about high blood pressure when it is more than 95th centile, right? In a patient come to the ward, when you check the blood pressure, in children, the blood pressure is normally lower than the adult value. So blood pressure is gradually increase with age to reach the adult value during adolescence, right? So at any age, if you take a blood pressure recording, you have to compare with the nomogram and to decide whether it is high or low, right? So generally we take it more than 95th centile is what taken as hypertension, but in children with chronic kidney disease, we try to keep it at the 50th level, so that the damage is made, make sure that there is no hypertension damage in the kidneys, right? So if there is blood pressure more than 90th centile, you don't with 95th centile, anything above 90th centile, we start treatment. right? So this is to reduce the progression of kidney disease by hypertension, right? So you treat them when the blood pressure reaches persistently more than 90th centile for that particular age group. And then you try to keep the proteinuria less than 300 milligram per square meter per day. And that is at least 1 gram per day, less than 1 gram per day. Now, proteinuria, I said that also causes progressive renal damage, right? So, the drug of choice to reduce proteinuria is ACE inhibitors, right? So how does they work? Any idea? How ACE inhibitors work? How does ACE inhibitors reduce proteinuria? What category of drugs are they? How do they produce the antihypertensive effects? Angiotensin converting enzyme inhibitors, or these are angiotensin receptor blockers, right? ARB again, angiotensin receptor blockers or angiotensin converting enzyme inhibitors, ACE inhibitors. These are captopril, enalapril, those are the drugs. So these are angiotensin converting enzyme inhibitors. Angiotensin is produced by the renin acting on angiotensinogen in the blood. Angiotensin 1 is converted to angiotensin 2 by the ACE, angiotensin converting enzyme. Angiotensin 2 is the most potent vessel constrict of the body, right? Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, which is blocked by captopril, right? 2 is the most potent vasoconstrictor. So when you block this enzyme, there is vasodilatation. So in kidney disease, it has additional advantage. It dilates the afferent arteriole more than the efferent arteriole. Sorry, efferent arteriole more than afferent arteriole, right? So the going away from the glomeruli is dilated more than the arteriole that bring in blood to the glomeruli. So what happens? Interglomerular pressure will decrease. Just the opposite of hyperfiltration injury, right? In hyperfiltration injury, the efferent arteriole is constricted, afferent arteriole is dilated. But what ACE inhibitors are doing it dilates both afferent and efferent arterioles. But the efferent arteriole is more dilated than the afferent arteriole. So the interglomerular pressure is reduced. So the filtration is reduced, right? And that will reduce the proteinuria as well. So that will reduce proteinuria. That will reduce the damage of nephrons by proteinuria, right? And then if there is a hyperlipidemia, protein restriction is not recommended in children, right? Because high protein diet actually causes increased filtration even in normal people. High protein diet causes hyperfiltration even in normal people, not only in kidney patients. In normal patients, high protein diet will increase the filtration. So in adults, we generally tend to restrict dietary proteins, but in children, we don't do it because they are growing and they need proteins, right? And hyperlipidemia, again, no data on children about using anti-lipid drugs to control hyperlipidemia, right? So that's how we generally try to stop the progression of disease, right? So what can we do in the long-term management? One thing is nutrition, right? In these children, we have to manage the nutrition. This is one of the major areas which is different from adults in the management, right? As I told earlier, the adults have stopped growing, children are still growing, right? So we can't have strict dietary restrictions in children because they have to supply enough nutrition for their growth, right? So generally we give all the nutrients in the normal daily requirement amounts. We don't restrict their nutritional intake, right? So if they are malnourished, we go up even more than the normal requirement, 125% of the normal requirement if they have malnutrition, right? So there's no dietary restriction, and we don't restrict proteins. We give normal protein requirement, right? And if they are on dialysis, we had to give excess protein requirement as well, right? This is one of the main difference between adult and children management. In children, we restrict proteins, but in adults, in children, we give normal protein diet. If it is non-dialysis, that is dialysis stage 5, no? Above 5, we give normal protein intake, but if there is dialysis taking place, then we give more than the normal requirement for survival, right? And if there is the dyslipidemia, then we can cut down the amount of fat, right? So that normally about 30% is produced by calorie count is produced by fat. We reduce it by 10% if there is dyslipidemia. And we'll restrict phosphate and salt in the diet. Phosphate because there are hypophosphatemia, salt because there is hypertension. So we need to restrict these two. And vitamins, again, normal recommended daily allowance is given, right? The normal amount that's needed for child given. But if they are on dialysis, during dialysis, they lose vitamins, especially water-soluble vitamins. So if they're dialyzed, we have to give additional amount of vitamins, right? So that is the, in a nutshell, about nutritional management in chronic kidney disease. And this is important fact is, they should be given high biological value proteins. That means out of proteins we take in the diet, right? Part of it is taken to replace the losses of the body, the tissues that have been destroyed by day-to-day activities. To replace them, we use proteins, right? Apart from that, adults like you and me, we don't need any more proteins. We need proteins to replace structural and functional proteins that have been destroyed day-to-day. If you take more proteins than that, what will happen? Those proteins will be deaminated and utilized for energy production or stored as fat for future use of energy, right? So you have to take, for an adult, you need to take only the amount of protein that is needed for replacing the loss of protein from the body. But in children, we need to take more than that because we need to deposit tissues for the growth, right? So for child, you need proteins, not only for the replacement of loss of proteins from the body, but for the deposition of new tissues in the body. Right. So for that, you have to give the proteins in high quality proteins. That means the biological value. That means you are giving proteins with the amino acid composition, which is ideal for the body. So say if you take a protein like soya, potatoes, dumbella, right? Those are high protein levels. But though they have high protein levels, their biological value is less, because they contain some amino acid in excess amounts, which are not needed in that amounts in the body. So if we take those proteins, those amino acids are deaminated and utilized for energy production and fat storage, not used for protein synthesis. Whereas breast milk, if you take breast milk, in breast milk, the proteins you got in breast milk is exactly the amount that we need by the baby for protein synthesis and tissue deposition. So almost all the proteins ingested by child by breast milk is utilized for protein synthesis. So very small amount will be deaminated and produced as urea. That's why newborn babies who are on exclusive breastfeeding has low blood urea levels compared to a child who is on formula milk, right? Because most of the amino acids ingested by the child with breast milk will be converted to proteins, right? So biological value is how much of protein in the diet is converted to protein as a percentage, right? If you take breast milk, it's almost 100% biological value. The next best protein is egg white. Albumin egg white. Give me a second. I've got a call. Give me a second. Oh. Okay. Right. So the best is to give animal proteins. Right. Animal proteins generally have a higher biological value compared to plant proteins, and out of that, egg is the best. Right. After breast milk, egg has the highest biological value. Right. So try to give high quality proteins. So they will be producing less amount of ammonia. Right. Ammonia is produced when amino acids are broken down to produce energy or fat. So if you are not breaking down amino acids, you don't produce ammonia. Ammonia is the one that is converted to urea, right? So in this children with chronic renal failure, they can't excrete the urea. We are trying to reduce the production of urea. The way to reduce production of urea is giving high quality protein in the diet. Okay, understood? Arjun. So then the management of growth failure. That was about the diet, right? And the growth, generally, you have to monitor the growth, right? They have to periodically monitor the growth depending on their glomerular filtration rate. And if the growth is suboptimal, you can give growth hormone therapy. I told there is growth hormone resistance. So you have to give a higher dose of growth hormone to get the normal response, right? So they have to give growth hormone daily, subcutaneously, right? This is the amount that you needed. So again, child need to be counseled about this, having daily injections, right? You can't give it orally because it get digested, right? So you got started daily, but then there are again side effects. They get hyperglycemia with the growth hormone. They can get more metabolic bone disorder get worsen, and they can get intracranial pressure increasing. That's what I call serotumor cerebri. They can get benign intracranial hypertension, right? So for the growth failure, one thing you can do is optimize the nutrition, minimize the acidosis, and then give the growth hormone levels, right? So how to treat the acidosis? You give by giving sodium bicarbonate, right? Orally. So try to maintain serum bicarbonate level around 20 to 22 milliequals per liter. This is the level to be maintained. That is the normal level, right? So you have to give supplements 2 to 3 milliequals of per kg of bicarbonate if the bicarb levels are below 15 milliequal per liter, right? So bicarb giving is not easy, as it said, because it's not a palatable thing. So when the bicarb levels are below this, you start bicarb supplements by 2 to 3 milliequal per liter. So you are trying to prevent the acidosis, right? Any questions up to now? Anything you want to ask? Anything to clarify? No? Right. Okay, we'll go on. Right? Then you have to manage their metabolic bone disorder as well. Now, this is a bit of too much of information here for you all. But if you want to read it, right? So mainly, you have to prevent the metabolic bone disease. That is, you want to have optimum bone growth, as well as reduce the bone resorption by parathyroid hormone. Right? For that, you have to give adequate amount of calcium phosphate levels, and you have to measure the parathyroid hormone levels to see whether he has increased parathyroid hormone secretion. The patient is going into secondary or tertiary parathyroid hormone levels, right? So you can give restrict the phosphate in the diet, right? You can use calcium carbonate or acetate as phosphate binders to prevent they get absorbed, right? Sometimes they can hypercalcemia, so you can give calcium binders. And if there is vitamin D deficiency, you can give vitamin D. And you can give vitamin D analogs, which will supply the direct active form of vitamin D. Right? So, main steps in managing metabolic bone disorder is giving the active form of vitamin D, 1-alpha from outside. That is 1-alpha from outside, that the active form of vitamin D, and then restricting phosphate in the diet. And if you can't control it, that you use phosphate binding substances to reduce the phosphate absorption. Right? So that's the management of metabolic bone disease. Then sometimes these children who are on end-stage, chronic kidney disease can have acute and chronic renal failure, right? A child who is on acute chronic renal failure can get a urinary tract infection, and that can predispose child to go into acute renal failure. Or child can, with a chronic kidney disease, can end up with a hypovolemia for some reason, like blood loss or something like that. And that will produce acute and chronic renal failure, right? So that will further damage the existing surviving nephrons and worsen the chronic kidney disease. So you have to make sure that you avoid any factors that would produce acute kidney injury, right? Like intercurrent infections, right? And when you're using antibiotics, not to use nephrotoxic drugs. Then dosage intervals should be kept at such that you don't damage the kidneys. So things like that you have to avoid, right? And then in addition, you have to give the immunizations, all the vaccines as in the normal schedule, because as they go on, they'll be more immunosuppressed and they're more likely to get the infections. But when you are giving live vaccines, make sure the child is not immunocompromised, right? So better to give the live vaccines when the child's immune system is competent, right? And especially if you're planning a transplant, make sure the live vaccines are given and completed, because once the transplant is done, we'll be using immunosuppressive drugs to prevent rejection, and that will make all the live vaccines contraindicated, right? So especially JE and MMR, right? We don't have an alternative inactivated vaccine for those two. JE, there was an inactivated vaccine at the moment we not available, right? Earlier there was a kill vaccine for JE, which was given as 4 doses, but now we are using the JE live vaccine, single dose live vaccine. With that, the killed vaccine is not coming nowadays, right? So polio, of course, you can get the killed vaccine, right? MMR does not have a killed vaccine. So you have to make sure that you complete the immunization program as early as possible before the child's immune system has been shut down and not optimally functioning, right? And then if you think child need renal displacement therapy, that is stage 5, when the patient has lost significant amount of nephrons and the GFR is less than 15, then you have to think of renal replacement therapy. That means peritoneal or hemodialysis. And then with that, you have to have a transplant program running it hand in hand. No point just doing the peritoneal or hemodialysis without having a renal transplant program inside, because you're just only prolonging the agony of the patient, right? So this should be going hand in hand. So if you're going for a dialysis program, that should be planned for a transplant as well, right? Otherwise, you'll just replacing them. How long can they go? So adult can go on with dialysis for about 5 to 10 years, but a child can't go on dialysis for 60, 70 years, right? So there should be a coupled transplant program arranged with the dialysis treatment. Okay. So this is one of the most important parts of any chronic illness, right? When managing any chronic illness, you have to make sure that you talk to the parents, and if the child is big enough, talk to the child and explain about the condition. Tell what's wrong with the child and what to be expected, how the disease will progress, right? What complications we anticipate, and how the outcome would be, right? And what are the options available, right? So discuss with them and get them involved in the management, the decision making, get them involved and take their views and opinion as well for decision making, right? And then, especially in kidney disease, tell them about the availability of dialysis, cost of dialysis, and then the possibility of a renal transplant, and then just not only about the possibility of renal transplant, the post-transplant management as well, about the cost of medication, right? The cost of follow-up, right? And without proper follow-up and proper anti-rejection therapy, the kidney is going to fail. So most of the time, they will initially agree for a transplant because at that moment they only think about the problem at acute problem, how to solve the acute kidney failure, right? But they don't think about how the child going to be managed in 10 years time, right? Ultimately, what happens is that they lose everything. They spend all their money on it. Then they sell their jewelry. Then they sell their land, their houses, everything. And all the entire family is on the road now. And then they can't afford any more anti-rejection drugs. And then they stop anti-rejection drugs. And the child lose the kidney. Donor lose his kidney, donor kidney. And the entire family is in the road. Right? So that type of situation is actually sad. Right? So it should be long-term plan management. Right? Decide which child could be offered a transplant program. If you are offering a transplant program, there should be long-term management goals, and there should be enough facilities to support the child and the family in the long run, not for 1 year, not for 2 years, because the management, the cost, and all the other supportive treatment is expensive and going to be lifelong. Right? You can't say you want 1 year and stop anti-rejection drugs. The moment you stop the anti-rejection drugs, the transplanted kidney will be rejected. Right? So it's important counseling and discussing, getting parents involved and give them informed on all the possibilities and resources and outcome available. Right? So that's enough for you all. Right? So in a summary, what you remember is chronic kidney disease is not renal failure, right? Renal failure is end-stage renal disease, that is at the last moment. The process through which a normal kidney end up in end-stage renal disease is what you call chronic kidney disease. Right? So there's acute injury which causes renal damage, and due to that there is hyperfiltration which causes the progressive damage, and then there are multiple complications they get, and all the complications contribute to further damage, right? And then ultimately child will end up with the end-stage renal disease. So what we can do is to slow the progression of a child going into the chronic end-stage renal disease. Though the goal of management is delaying the child going into end-stage renal disease. So it ultimately will happen, right? Because it's a progressive thing. So our main role of management is delay in the progression of chronic kidney disease, ending up in the end-stage renal disease, and keep the child in the optimum condition, best possible care, and keep him as comfortable as possible until either a transplant program is initiated, right, or child end up with the end-stage renal disease, right? So that's it about this lecture. Anything you want to discuss? Anything you want to clarify, or anything that you don't agree, all right? We can, what 5-10 minutes, we can discuss on that. Anything you want to ask? Any questions? Yes, no? So in event of no other questions, we'll stop here, right? So if you have any questions or later you want to discuss anything, you can just put it in your Just drop me an email. I'll try to answer your questions. Right. So you stop it there. Right. Okay.
Sir,
Yeah.
can you explain the fluid retention in the CKD?
Sorry.
Fluid retention in the CKD.
Fluid retention. Now that is due to decrease urine glomerular filtration. Right. When the GFR is reduced, right, and then that will cause increased aldosterone secretion, right, because the RAM is activated, and the amount of fluid filtered is less, and the amount of fluid reabsorbed is more. So there is fluid retaining in the body.
It
It's a
is
product
not only in the end stage kidney disease, or it is appearing early stage
Initially, there's
also?
compensation until end stage renal disease. You don't get much of the symptoms, right? Much of symptoms, lot of symptoms are shown because before that there's compensatory pace. The other nephrons are compensating for the lost nephrons. So most of the symptoms will start to appear with the end-stage renal disease, right? So what you have is mainly polyuria during early stages of chronic kidney disease. What you will observe is polyuria because these other nephrons are hyperfiltrating, and they filter more than what they can reabsorb. So this nocturia, polyuria is a feature of actually chronic kidney disease. Unlike acute kidney disease, acute kidney injury, there is oliguria. Like chronic kidney disease can have polyuria initially, and then once they get into the end-stage renal disease, when the GFR is low down to about 15, then they get the fluid retention. Right?
Okay, thank you, sir.
Any other questions?
Sir,
Yeah.
so by giving ACE inhibitors, so we are further decreasing the GFR. Isn't that a problem to manage the proteinuria? We are further decreasing the GFR.
Yeah, but this is not the issue. Not actually the GFR not the issue here because GFR anyhow is hyperfiltrating now. Glomerular hyperfiltrating, right? Hyperfiltration itself is damaging now.
Yeah.
Right. So we can control the hyperfiltration also by that means. By giving ACE inhibitor, you control the hyperfiltration as well as proteinuria and all. So you can control the hypertension, you can control the proteinuria, and you can control hyperfiltration also. Right?
Okay, sir. Right. Thank you.
Anything else? So then we'll stop it here, right? Okay. Right.